Hello everyone and welcome to this lecture. I'm Professor Shagu Oricha Bello, and today I'm going to walk you through one of the most important chapters in antimicrobial chemotherapy, the sulfonamides. These were the very first synthetic antibacterials, and even though they're an old class, understanding them gives you a beautiful foundation for how selective toxicity actually works. Over the next few slides, I'll take you through their chemistry, how they kill bacteria, how we classify them, where we still use them today, their side effects and resistance, and I'll leave you with some memory aids to make it all stick for your exams. So grab a pen and let's get started. Let me set the scene with a bit of history, because this is genuinely one of the great stories in medicine. Before the 1930s, a simple streptococcal infection could kill you. We had nothing to treat systemic bacterial disease. Then in 1932, Jahar Domak discovered that a red dye called prontosol could cure streptococcal infections, and that work earned him the Nobel Prize in 1939. Here's the twist I want you to remember. Prontosol itself is inactive. It's a prodrug that the body converts into the real active molecule, sulfonamide. And the reason these drugs harm bacteria without harming us comes down to selective toxicity. Bacteria have to build their own folate from scratch, whereas we simply get ours from our diet. Today, sulfonamides have largely been replaced as solo agents, but as you'll see, they're still very much alive in combination. Now let's look under the hood at the chemistry, because the structure explains everything the drug does. The core molecule is sulfonamide, a para-amino benzene sulfonamide. I want you to notice three things. First, that free para-amino group at the top, it's essential for activity, and it either has to be free or convertible in the body. Second, the sulfonamide group, that's what mimics PABA, and the acidic N2H is what lets it bind. And third, we can substitute the amide nitrogen, and that's how chemists tune potency, solubility, and how long the drug lasts. The big idea here is that this molecule is a structural look like a PABA, para-aminobenzoic acid. Hold that thought, because it's the key to the mechanism on the very next slide. So here's how they actually work, and this is the slide I really want you to master. Bacteria build folate in a pathway, and PABA is the starting substrate. The enzyme dihydroxyapatite synthase, DHPS, normally converts PABA into dihydroxyapatite. Because a solamide looks just like PABA, it competitively inhibits the HPS. So the bacterium can't make folate. No folate means no purines, no DNA, no proteins, and the bacterium simply stops growing. On its own, that's bacteriostatic. Now look one step further down the pathway. Trimethoprim blocks a different enzyme, dihydrofolate reductase, or DHFR. When we block two sequential steps at once, the effect is synergistic, and the combination actually becomes bactericidal. That sequential blockade is the whole reason cotrimoxazole exists. Let's organize these drugs so they're easy to remember. We classify sulfonamides mainly by how long they act and where they act. The short-acting ones, like sulfoxazole, are absorbed and excreted quickly. The intermediate acting group, sulfamethoxazole, and sulfadiazine. These are the workhorses for systemic use. Long-acting agents like sulfadoxine are around much longer, though we use them less now. Then we have the poorly absorbed ones that stay and act in the gut, like sulfasalazine, the topical agents for skin, eyes, and burns, like silver sulfadiazine and mafenite. And finally, the related sulfones, most importantly dapsone, which we use in chronic infections like leprosy. If you can slot a drug into one of these 6 buckets, you're in great shape. This table is really your quick reference cheat sheet, so let me highlight the ones worth memorizing. Sulfamethoxazole. You almost always see it paired with trimethoprim as co-tremoxazole. Sulfadiazine partners with pyrimethamine for toxoplasmosis. Sulfoxazole is for urinary tract infections. Sulfadoxine goes with pyrimethamine for malaria. Sulfasalazine is for ulcerative colitis and rheumatoid arthritis. And notice it's poorly absorbed, which is exactly why it works in the gut. Then 2 topicals, silver sulfadiazine to stop burn wound infection, and sulfacetamide for eye infections. Learn the drug, its class, and its headline use, and you've got this whole table. Co-tremoxazole deserves its own slide because it's the sulfonamide you actually prescribe. It's a fixed dose combination of sulfamethoxazole and trimethoprim that blocks those 2 sequential steps in the folate pathway we just talked about. That sequential blockade is synergistic, so the pair is bactericidal even though neither drug is on its own. It's formulated at a 5:1 ratio of SMX to TMP, which gives the ideal 1:20 ratio in the plasma. It has broad gram-positive and gram-negative cover, and resistance develops more slowly than to either drug alone. So where does it shine? It's the drug of choice for pneumocystis jirovecii pneumonia, and it's used in uncomplicated otitis, nocardiosis, toxoplasmosis, stenotrophomonas infections, some MRS skin infections, and traveler's diarrhea. If you remember only one sulfonamide from this lecture, make it this one. Let me pull the clinical picture together so you know when these drugs really earn their keep. In urinary tract infections, sulfonamides were historically a mainstay, and co-tremoxazole is still used for susceptible cystitis. In the respiratory world, co-tremoxazole is central to both treating and preventing pneumocystis pneumonia. For protozoal infections, we combine sulfadiazine with pyrimethamine for toxoplasmosis and use sulfadoxine for malaria. In the gut, sulfasalazine treats ulcerative colitis and rheumatoid arthritis. For burns and skin, silver sulfadiazine and mafenite prevent wound sepsis. And in the eye, topical sulfacetamide treats bacterial conjunctivitis. 6 areas, that's your map of where sulfonamides still matter today. Now the part that keeps our patients safe, the adverse effects, and these come up constantly in exams. First, hypersensitivity rash, fever, photosensitivity, and importantly, cross-reactivity across the whole sulfur class. At the severe end, we worry about Stevens-Johnson syndrome and toxic epidermal necrolysis. Rare, but potentially fatal, crystalluria happens because the metabolites are poorly soluble and precipitate in the urine. So keep patients well hydrated and alkalinize the urine On the blood side, expect hemolysis in G6PD deficiency, plus a granulocytosis, thrombocytopenia, and aplastic anemia. Because these drugs displace bilirubin, there's a real risk of kernicterus, so we avoid them in late pregnancy and in neonates. And finally, watch the drug interactions. They potentiate warfarin, sulfonylureas, and phenytoin by displacing protein binding. No antibiotic talk is complete without resistance, so let's see how the bacteria fight back. The main mechanism is an altered target enzyme. Mutations or plasmid-borne DHPS with low affinity for the drug, and this is now so widespread that we rarely use these drugs alone. Bacteria can also simply overproduce PABA, the natural substrate, outcompeting our inhibitor. Some reduce drug uptake or pump it straight back out with efflux, and others bypass the problem entirely by scavenging performed folate from their environment. The practical lesson here is that combining with trimethoprim slows the emergence of resistance, so we reserve these drugs for organisms we know are susceptible and for confirmed indications. Alright, this is my favorite slide. Let's lock it all in with some memory aids. The first is the word sulfur for the key adverse effects, S for Stevens-Johnson syndrome, U for urinary crystalluria. Keep them hydrated, L for low blood counts, including the G6PD hemolysis, F for fetal and neonatal risk, that's kernicterus, and A for allergy. Next, to remember the enzymes, think sulfur synthase. Sulfonamides block the synthase DHPS, while trimethoprim blocks the reductase. DHFR, 2 steps, 1 pathway. And finally, my one-liner for selective toxicity: bugs BUILD folate, humans BUY it. Bacteria have to make it themselves, so the block hurts them and not us. Say those 3 out loud a few times, and they'll stick. Let's wrap up with the big picture. Sulfonamides were the first synthetic antibacterials, and they work by selective toxicity, blocking bacterial folate synthesis at DHPS. We classify them by duration and site of action: short, intermediate, long-acting, poorly absorbed, topical, and the related sulfons. Cotremoxazole pairs sulfamethoxazole with trimethoprim for that synergistic bactericidal sequential blockade. Keep a close eye on the toxicities. Hypersensitivity, Stevens-Johnson and TEN, crystalluria, G6PD, hemolysis, and kernicterus. And remember our mantra: bugs BUILD folate, humans BU it, along with the sulfur acrostic. Thank you so much for watching. If you found this helpful, please like and subscribe, and I'll see you in the next lecture.